Hello, I'm Deborah McEdward, one of the research coordinators for the National Dental Practice-Based Research Network. We're excited you've decided to join the network. We look forward to working with you. This orientation presentation should give you a better idea of the makeup of the network, the history, and where we hope to go. We hope you enjoy it, and we look forward to working with you. Welcome to an introduction and orientation to the nation's network. This presentation will give you information about practice-based research, the goals of the network, and how the network was formed. You will find out more about the levels of participation, how the studies are developed, and some of the rules and regulations required for working with patients as research subjects. You will also learn about some other benefits of enrolling and being part of a national effort to answer questions about dental practice. Finally, you will be introduced to the staff of the network in your region and how to contact them. What is a dental practice-based research network? It is a group of individuals in dentistry that have joined together with an administrative base to investigate questions on dental practice and share experiences and expertise. The network does real-world research in the practices where it will be used and where the majority of patients receive their care. Practice-based research is different from other types of research. Laboratory research involves treatment in the investigational stage when it is not ready for use in humans. Clinical trials do work with patients, but on a limited basis, and generally under ideal conditions. Practice-based research is done in practices to see what works and why in real life with real patients. Since the research is done in real time with actual patients, not under ideal circumstances, it is applicable to practice situations. Studies in academic or other environments may be rigorous, but are not always relevant to private practice. Laboratory studies may be well designed, scientifically sound, and statistically significant, but impractical for a busy clinical practice. Research needs to be done with the end user in mind. By having research in the practices that will use the information, we can shorten the lag time for implementation. To quote Lawrence Green, "If we want more evidence-based practice, we need more practice-based evidence. By answering questions in a practical and practice-based way, we can make a difference now." The National Institute of Dental and Craniofacial Research is part of the National Institutes of Health. They are active in funding research for the dental community to improve patients' health and have funded the National Dental Practice-Based Research Network. Medical PBRNs have been in place for a number of years. NIDCR decided that the concept would work well to answer questions in dentistry, and in 2005 funded 3 separate networks for a 7-year period. Northwest Precedent, one of the networks, was located in the Pacific Northwest. Pearl was focused on dentists in New York and the New England states, but included some practitioners in other areas of the country. The Dental Practice-Based Research Network was comprised of 5 different regions, 4 in the United States and the other region comprised of the Scandinavian countries. Additionally, all 3 networks collaborated in joint studies under the name of CONDOR, the Collaboration on Network Dental and Oral Health Research. When NIDCR funded the networks, skeptics were not sure it would work. Would we be able to recruit a large number of practitioners? Could we establish the necessary regulatory and contractual relationships? Would busy clinicians be effective at doing studies in their practices? Would practitioners contribute ideas for research projects? Would they participate at every step of the research process? The answer to all these questions was a resounding yes. Network studies have focused on a variety of practitioner-suggested topics, including cracked teeth and remineralization for white spot lesions in orthodontic treatment by Precedent, and endodontic, cervical lesion studies, and sleep bruxism by the Pearl Network. The DPBRN studies included repair versus restoration studies and best practices in doing in-office research. Collaborative studies between the three previous networks included osteonecrosis and TMJD. More information on any of these studies is available at NIDCR or the National Network website. The Dental Research Network engages practitioners at every step of the process. The study ideas come from the practitioners who help design the study. Study feasibility and data forms are tested in practices during the pilot testing phase of the projects. Data collection is done in the offices with the trained staff and dentists obtaining consent from patients and filling out provided forms. After data analysis at WESTAT, our coordinating center, results are provided to the practitioners. Practitioners are engaged in the manuscript preparation and presentations at the local, regional, and national levels. The results from the three networks were substantial and convinced NIDCR to fund a single nationwide network for an additional 7 years. The National Dental PBRN was established in all 50 states and the American territories. Each region has a local administrative site at an academic or research institution. The mission of the National Dental Practice-Based Research Network is to improve oral health by conducting dental practice-based research and by serving dental professionals through education and collegiality. Our aim is practical science done about, in, and for the benefit of real-world clinical practice. Dental practitioners and other interested parties are invited to join. Non-practicing individuals, such as academic faculty, students, and those in public health or other areas that do not actively see patients, are invited to join at the informational level to receive newsletters and correspondence. Dentists and hygienists, or dental therapists, are invited to join at the limited level to participate in surveys and questionnaires, or the full level, where they would also conduct research in their practices. It is the desire of NIDCR and the network staff that this will become a precious national resource, a source of information for practitioners and their patients, instrumental in testing ideas that may improve dental care and impact how care is provided, a venue to speed up the translation of evidence into practice. Having the entire nation in one network should also provide enhanced opportunities for professional collaboration. The network collaborates with other organizations as well to identify win-win opportunities. Practice-based research provides answers to what works, when, and for whom, and allows our profession to lead rather than be led. Patients are interested in in-office research and see it as contributing to their well-being, which enhances the public's view of dentistry's commitment to research and quality improvement. Funding for the national network is through NIDCR, which provides technical consulting and guidance initially, and oversight and monitoring for safety in the studies. All the studies are approved by a committee of practitioners and have approval of institutional review boards. This schematic diagram gives you an idea of the structure of the organization, and the regional practitioners are highlighted at the center of the schematic because they are the most important part. The executive committee is the main decision-making body of the network. The committee has a practitioner representative from each of the 6 regions. Additional voting members are the National Network Director and Coordinating Center Director, and a program official from NIDCR attends meetings in a non-voting capacity. Executive committee members serve 3-year terms. Most meetings are by phone conference with face-to-face meetings at least once each year. Regional representatives to the Executive Committee must be a licensed general dentist or dental hygienist who sees patients in a general practice setting and have participated in at least one clinical study. Since face-to-face meetings are infrequent, representatives must have internet access and be willing to communicate by teleconference or video conference. The steering committee is responsible for implementation of the studies approved by the Executive Committee. Directors of each of the 6 regions, as well as the National Director and Coordinating Center, are the voting members of the committee. Other key personnel, including the deputy directors of each region and regional coordinators, attend in an informational capacity. The National Network Director, located at the University of Alabama at Birmingham, oversees the administration of the network. Specific scientific and administrative functions are provided by WESTAT, the coordinating center, located in Maryland. The Publications and Presentations Committee is responsible for monitoring and facilitation of publications and presentations network-wide. The committee responsible for dissemination of information and communicating with practitioners is located with the network chair in the South Central region at the University of Alabama at Birmingham, while the component overseeing training and education of practitioners for involvement with human subjects research is located at the South Atlantic region at the University of Florida. Once a study has been approved, a study team is formed to further develop the protocol, do feasibility and pilot testing, data collection, data analysis, and eventually, study closure activities. Since practice-based research is done in offices with patients, oversight is necessary. Any federally funded research with human subjects requires approval by an institutional review board. This ensures that research participants' rights and interests are protected. Each region has an IRB and works with that board to protect patients' rights. The National Institute of Dental and Craniofacial Research provides the network with an oversight committee to monitor protection of participants, compliance with the protocol, data quality, and study progress. Once an idea is suggested by practitioners, it takes many steps before the study is brought to an office. Study development is a multi-step process that requires review by the Executive Committee, approval by NIDCR, development by a study team, and IRB approval before implementation. To be a clinical investigator and participate in in-office research, practitioners must be approved by an institutional review board for each study they wish to participate in. An agreement and informed consent must be signed. In addition, the practitioner must agree to the statement of work for the project, state that there is no financial conflict of interest, and agree to keep the study information confidential. Practitioners decide if they are interested in participating in a study. Members of the network have no requirement regarding participation. Remuneration is given for the time involved with the study, not for enrolling patients. To participate in in-office research, practitioners are required to have training in human subjects protection and HIPAA. This training is available online. Those practitioners who will be participating in in-office research will be contacted by a research coordinator regarding the required training. Individuals who have joined the network find a variety of benefits of membership. Projects contribute to improved quality of dental care by providing a scientific basis for dental procedures. The research expands the vision of patient care with the quality improvement component and provides a focus on clinical excellence by attention to one particular clinical practice area at a time. Logistics of daily operations are improved by providing short-term attention to specific areas of clinical practice. Practitioners are the ones who decide what studies are done and what treatment is done, not a third party. Communication with patients is enhanced when practitioners can demonstrate that they have a scientific basis for clinical practice. Research studies serve as team builders by engaging the entire staff in the excitement of discovery and quality improvement. Practitioners can not only see what is effective in their practices, they can compare their practice to other practices anonymously by comparing study results. With involvement in the research, practitioners have the potential to present research findings at local, state, and national meetings and conferences. And participation in research distinguishes a practice from other practices and can promote a practice in the eyes of patients, thereby increasing the practice's visibility and stature. Participation also provides venues for interactions with fellow investigators. Continuing education credits are provided for training, for studies, and participation in annual meetings. Practitioners are also provided with certificates to display, as well as the financial remuneration for research time. In addition, annual meetings are held in each region for participants to interact with other network members, to discuss study results, participate in long-range planning, and develop new study ideas. Members are encouraged to give presentations at meetings, serve on committees developing and planning studies, and participate in the studies by co-authoring manuscripts for publication. Members are kept abreast of progress and results on a regular basis. Interact and stay connected. The network is active in a variety of social media, including Facebook, LinkedIn, Twitter, and YouTube. We invite you to check out the website for information on studies and publications, as well as a discussion forum. Each region has a research coordinator as the main contact for questions and comments. The following slides give information on staff for each specific region and the coordinating center. The South Central region, Alabama, Arkansas, Kentucky, Louisiana, Mississippi, Tennessee, and West Virginia, is administered through the University of Alabama at Birmingham. The South Atlantic region, Florida, Georgia, South Carolina, North Carolina, and Virginia, is administered through the University of Florida. The Northeast region, Maine, New Hampshire, Vermont, Massachusetts, Pennsylvania, Rhode Island, Connecticut, New Jersey, New York, Delaware, Maryland, District of Columbia, Puerto Rico, and the U.S. Virgin Islands, is administered through the Eastman Institute for Oral Health. The Southwest region, Texas, Kansas, Oklahoma, Arizona, and New Mexico, is administered through the University of Texas Health Science Center at San Antonio. The Western region, Alaska, American Samoa, California, Colorado, Guam, Hawaii, Idaho, Montana, Nevada, the Northern Mariana Islands, Oregon, Utah, Washington, and Wyoming, is administered through the Center for Health Research in Portland, Oregon. The Midwest region, Illinois, Indiana, Iowa, Michigan, Minnesota, Nebraska, North Dakota, Ohio, South Dakota, and Wisconsin, is administered through Health Partners Institute for Education and Research. The Coordinating Center, WESTAT, is in Rockville, Maryland. Some publications from the previously funded networks can be found on the National Dental PBRN website or through the NIDCR website. We invite you to go to the site and review some of the studies that have been completed. Thank you for your participation and membership in the National Dental Practice-Based Research Network. We encourage you to go to the website and explore all we have to offer. If you have further questions, contact your research coordinator, and we look forward to working with you to improve and promote oral health.